patients with depression, and I think that sometimes you have problems with patients with depression, because patients with depression sometimes don't respond to treatment. And this is a very big problem, because the patient is sick and we have to treat them. What I will tell you in the next 30 minutes, 45, is to try to solve this problem of resistant depression. But before, we have to understand what is treatment-resistant depression. There are different definitions. Failure to reduce depressive severity of 50%, failure to complete remission, but this is probably the most common. Failure to respond to one or more antidepressants. So we have a patient with depression. We treat patient with one antidepressant, doesn't work. With a second antidepressant, doesn't work. And then what we do? This is the problem. This is resistant depression. This is probably the most comprehensive definition. Failure to reduce depressive severity by at least 50% following adequate treatment with antidepressants. So you have a patient with depression, you treat the patient, you have a response. If you don't have a response, the patient remains depressed. And this is treatment-resistant depression, chronic depression. How many patients have treatment-resistant depression? Many patients have treatment-resistant depression. Only 40% have remission. Some have a partial response, but 25 to 30% have a non-response. So we are focusing on those patients who have difficulty in responding to antidepressants. Why is important to treat resistant depression? For a very simple reason, that if us don't treat treatment-resistant depression, we create a damage in the brain of the people. In particular, and we will show in the movie that I will show you later, in particular, we are creating a damage in the hippocampus. Probably not all of you know that hippocampus is the basis of depression. When you have depression, your hippocampus is smaller because of toxic activities that I will show you later. So when you have in front of you a patient with depression, if you could look with the eyes in the brain, you would see that the hippocampus is smaller. Not only hippocampus, also frontal cortex, other areas, but particularly interested in hippocampus. So depression is not a psychological status. Severe depression, of course. Severe depression is a medical problem that must be treated. Otherwise, if you don't treat them, this is what happens. An irreversible damage. I will explain. If you don't treat depression for 3 years, 6 years, 9 Hippocampus can be considered like a mascot. Mascots. If you don't do physical activity, if you stay in bed for a long time, your muscles shrink. Hippocampus is the same. If the patient is depressed, no thinking, no concentration, hippocampus goes down. If you don't treat depression, the hippocampus will be smaller, 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 year after year. And it is always more difficult to treat when the hippocampus goes down. Like it's difficult to do rehabilitation after bone fracture, road incident, if the patient stays for a long time without moving. The same concept. This is to answer to the question why it's important to treat resistant depression. If you don't treat, you do a damage. Then, resistant depression is a problem. Resistant depression is frequent. Resistant depression causes brain damage if untreated. Then we have to learn how to treat resistant depression in the best way. The reason for resistant depression probably stays in the genetic architecture of the brain. We published a lot on this. This is not part of the presentation of today. Just to tell you that genetics is important. In the future, it will be of help, but not now. Now, we have to focus on the clinical factors. And which are the clinical factors that can help us to understand if a patient has treatment-resistant depression? These ones. So we have some predictors. If a patient has a higher raise in severity, or particularly long duration of the episode, probably can have a resistant depression. Why? Because the hippocampus is smaller, so more difficult to treat. If the onset of the disease is very early, again, another reason. If the onset of depression is early, the hippocampus is suffering since many years. If you have other diseases like anxiety, if you had abuses during childhood, and if you don't have social support. So these are the clinical criteria for predicting resistant depression. So consider them. If you have a patient with these criteria, be careful, because it can be a resistant depression patient. But all treatment-resistant depression are really a treatment-resistant depression, not all. Many of them, the majority, are pseudo-treatment-resistant depression, not real treatment-resistant depression. In which sense? In the sense that resistant depression is failure to respond to two or more adequate trials of standard treatment. Adequate. Always consider the word adequate. When you use antidepressants, you have to use antidepressants at the right dose. I have seen many times psychiatrists that use antidepressant in the wrong way, or for a short period, or with insufficient dose. So the first strong message that I'm giving you today about treatment of resistant depression, always use the right time, 2, 3, 4 weeks, and the right dose. Many antidepressants don't block the serotonin transporter at low doses. So never use paroxetine 10, 20 milligrams. Never use sertraline 50 milligrams. Never use fluvoxamine 50 milligrams, and so on. You always have to reach the maximum tolerated dose. Tolerated. If you see side effects, of course you have to stop. But you always have to go to the maximum tolerated dose. Patients usually are treated with 40 of paroxetine, are treated with 100, 150 of sertraline, are treated with 200 or 300 milligrams per day of fluvoxamine. Because only in this way you are sure that the effect of the drug in the brain is indeed working. Particularly, this is true for venlafaxine. I've seen many times venlafaxine prescribed at 75 milligrams. It's doing almost nothing. Is blocking the serotonin transporter of a very low percentage. So you don't have any pharmacological. Venlafaxine must be used at the adequate dose. Of course, controlling for blood pressure, constipation, all the side effects. But venlafaxine, you should go up to 125, 300, 375. I had patients who were not responding with venlafaxine 150 and responded with venlafaxine 375. Don't be worried. Control for side effects. But if there are no side effects, there are no problem in going high. Is this common for you? Someone already does this high doses? Or no? You use high doses? No? No. Consider this.
Yes, I'm a neurologist, but I'm a neurologist and not a psychiatrist, but sometimes I use the doses you mentioned about of medication.
Okay. So I remind to all the others that drugs must be used at their effective level. If they don't block the serotonin transporter, the noradrenaline transporter, it's not like giving a drug. Moreover, remember that 10% of the patients are rapid metabolizer. Rapid metabolizer. It means that their liver works very fast. And therefore, they metabolize the drug very quickly. In those cases, you have to use very high doses, probably even above the threshold. Of course, discussing with the patient, informed consent, and so on. On the contrary, you can have some patients that are slow metabolizers, that their liver don't work very fast. In those cases, you have to use very low doses, because you see side effects. I had many patients that had side effects with 5 milligrams per day of paroxetine. And then I had to use 1 milligram, 2 milligrams. Not many, very rare, but it can happen. So, in average, use the highest dose. For some patients, you have to use even higher dose. For other patients, you have to use very low doses. And this is what I mean inadequate treatment trial, very quickly. Don't forget also this, patient non-adherence, very common. You have heard before about the difference in drugs in terms of tolerability. They are not all equal. Antidepressants are very different. Some of them can give a very high weight gain. Patients don't want weight gain. So if you give, for example, paroxetine, and the patient gains 5 kilos, the patient will stop medication and will not tell you because he's afraid. This is very common. So always investigate if the treatment that you are using is giving side effects. You will see later also sexual side effects that are another important side effect that patients don't like, obviously. So you have to choose the antidepressants in order to reduce as much as possible the side effect profile that is different from a patient to another. This is what is difficult, and this is what I'm trying to help you today, to choose the right drug for each patient. If a patient is very slim, a drug that gives weight gain is okay. If a patient is very old and no more sexually active, a drug that is giving sexual dysfunction is not a problem. But you have to decide case by case. You have to know for each antidepressant which is the profile of side effects to avoid patient non-adherence and intolerable side effects. These are extremely common phenomena, more than 50%. And then maybe you can think this is treatment-resistant depression. No. Is the patient not taking the medication? So, if you use the adequate treatment, more than half of what seems treatment-resistant depression will indeed respond. And this is why I'm here to give you an overview of what is adequate. Can be appropriate antidepressant treatment, or can be psychotherapy. This is something that is not much considered, but psychotherapy is very powerful in resistant depression, together with drugs, because psychotherapy changes hippocampus and the brain in the same way that antidepressants do it. So you can reach a better effect combining antidepressants and psychotherapy. Why CBT? Because it's the most studied and it's the most also less expensive. This is an example of how CBT works. CBT is aimed in changing the way, the automatic way that the depressed patient is thinking. The depressed patient is thinking always negatively. With CBT, you try to teach the patient to think a little bit more positively. In this way, with the help of the drug, you have a better efficacy. And CBT plus antidepressant is much better than antidepressant alone. All studies are very clear in this. If you combine psychotherapy and antidepressant, you have better effects than antidepressant alone. So let's go a little bit into detail. What to do in treatment-resistant depression once we are sure that it's really a treatment-resistant depression. First, we have to optimize the dose and the time of the treatment, and we already discussed this. Then we have other options. First, we can switch to another drug. We can combine antidepressants, or we can make augmentations with other compounds. Which is the best strategy? I'm sure that each of you has a different opinion. Optimize those we already discussed. If there is no response at all after a few weeks, you have to change that. But if you have a little bit of response after a few weeks, then you have to move the dose to the maximum tolerated for at least 1 month. This is the first step in treatment-resistant depression. But if it doesn't work, what we should do? We have different options. First option is the switching. What is switching? Switching is changing the antidepressant. The patient does not respond to sertraline, and we change to paroxetine. Is it good or not? I will tell you in the next few slides. This is the biggest study performed in US, study, more than 4,000 patients. At the end, 3,600, beginning of more than 4,000. What happens? That you see remission in the first treatment with citalopram in less than 40%. If you switch treatment, you have a remission in less than 30%. Again, less and less. So, switch is probably not the best way of treating treatment-resistant depression, because results are not so fantastic. Also, another study that we did in the group that I'm working with in Europe of treatment-resistant depression, we did a very interesting study. If a patient was not responding, we tried two different options, switch within class or different class. Because current international guidelines suggest that when a patient is not responding to one class, you should change class. When a patient is not responding to SSRI, serotonin, selective serotonin reuptake inhibitors, you change to drug that go to noradrenaline, for example. My opinion is that this is not the best option. Why? Because if a patient had some benefit from the first treatment and you change class, you have to start again from zero. You have to start again everything. You lose the benefit of the previous drug. In fact, when we do the across-class switching, the remission was 13%. But if we change within the same class, the remission is higher, 18%. What is the meaning? That if you switch within the same class, you maintain the effect of the previous treatment. If you are giving sertraline, blocking the serotonin transporter, and then you give paroxetine that is also blocking the serotonin transporter, you maintain the effect. If you give sertraline that is blocking the serotonin transporter, and then you give reboxetine that is blocking only the noradrenaline transporter, you have to start from the beginning. You lose time. So probably it's not good. In this other study that we did, demonstrates this concept very clearly. In this study of treatment-resistant depression, we compared the effect of citalopram and desipramine in different combination, sequential combination. And the results were very interesting. If you continue after the first weeks with the same drug, non-switch, it means continuation with the same drug, you have a much higher response and remission. If you change drug, you have much lower remission and response. Much lower. Why? The response is here. This graph is extremely interesting. I will explain you in detail. So imagine here there was 1 month of treatment without any response. And the patient was either continuing with the drug he was taking before, if he was taking citalopram, continuing with citalopram, it's like you are starting again from zero. You are starting again with a different brain system. This is why it is not correct, in our opinion, to change class. You lose time. If you continue to drive, you have a continuous response. If you switch, you lose 1 week. Is this clear? If you have any questions, I am here to answer.
What described on the side score, on the vertical score?
Hamilton. Improvement. Hamilton improvement. So in 1 week, there is no Hamilton improvement if you switch. If you don't switch, you have an average of about 15 points of Hamilton improvement. So, to summarize this part, switching is a relatively low efficacy. It's not a good idea to switch to a different class, because probably you will lose the effect of the first medication. Then what we can do? Another option is combining 2 antidepressants. It means patient is taking sertraline, not responding, and we are adding something else. Citalopram, fluvoxamine, whatever. 2 antidepressants. Is it good or not? Well, we did some kind of studies in the past, combining, for example, reboxetine in SSRI. We did a couple of studies. And for some patients, it's good. Patients were not responding to SSRI, and we put 2 or 4 milligrams of reboxetine. Different mechanism. So if the serotonin transporter way was not working, we added the noradrenaline transporter blockade. And for some patients, there was good improvement. And these are the details. Patient with depression, resistant depression, adding reboxetine, and some had improvement, some not, but some yes. So this is a possible strategy. The possible combinations are many. You can combine SSRI with reboxetine, SSRI with trazodone, or particularly SSRI with mirtazapine, because mirtazapine has a complementary effect on the serotonin receptor 2A. So with mirtazapine combined with SSRI, you have something more. Of course, you could also combine SSRI with tricyclics, but this is very dangerous because you know tricyclics are very toxic, so there is a big risk of side effects. So the combination is a very powerful strategy. Be extremely aware of interactions. Many drugs are metabolized by the same liver cytokines, and you can have very high plasma levels due to interaction in the liver. Very dangerous. So it must be done very, very cautiously. Second, there is the possible pharmacodynamic interaction. If you put 2 antidepressants in the brain, you can have a risk of serotonin syndrome. So it's a very powerful strategy, but with many, many warnings. And then there is no clear evidence about which specific combination is better. SSRI with reboxetine, SSRI with mirtazapine, nobody demonstrated that. And so let's go to the last option, augmentation. What is augmentation? Augmentation is to continue with the first antidepressant that is not working with something more, something that is not an antidepressant, something different, but that can enhance the effect of the I will show you a list of the possible augmentation strategies. The first, most famous, is lithium. All this information are taken mainly by the Maudsley guidelines, very useful guidelines that I suggest you to consult and to take it. Very detailed, very well done. So you can have a patient that is taking paroxetine, citalopram, anything, not responding. You already reached the maximum dose. You don't want to do a combination of two antidepressants, and then you start with augmentation. So you can prescribe, for example, lithium together with the antidepressants. Which are the positive aspects of lithium? Well, it is very well established, it is effective in good part of cases, well supported in literature, recommended by guidelines. The problem of lithium is that it is not very well tolerated. You know, lithium can be dangerous. Lithium can have toxicity quite easily. So, we must be very careful when we use lithium. Potentially toxic. You need to do the plasma monitoring every 3 months. So it's not an easy drug. But I can tell you that this combination of lithium plus antidepressant can be very useful, particularly in patients with some bipolarity. What means some bipolarity? For example, with a bipolar patient in the family. If your patient has depression, but has a brother or mother with bipolar disorder, probably you need to use mood stabilizers. Because there are some bipolarity genes, some bipolarity mechanisms in the brain. I am not talking here in particular about bipolar depression, that is very difficult. I refer you to a paper that we recently published in the American Journal of Psychiatry about all the suggestions how to treat bipolar depression. This is a different issue. Other suggestions. First choice. Stimulate thyroid. Add some thyroid hormones. Thyroid. This is usually well tolerated, good literature. It gives some energy to the patient. Again, the problems are that you must be very careful and monitor the plasma levels. You must not go too high of thyroid hormones. It can be dangerous. Some people suggest to combine olanzapine, but I will discuss this later. Also quetiapine, I will discuss this later, in this large graph that is talking about atypical antipsychotics. Many people, many guidelines suggest to use atypical antipsychotics in resistant depression, in combination with SSRI, in combination. Now the question is, which antipsychotic we should combine for a better efficacy? The first answer is that we must be very careful in using atypical antipsychotics in depression. Because even if they are atypical, they can have some side effects. Metabolic syndrome, not only weight gain, metabolic syndrome. Neurological side effects. They can also lead to tardive dyskinesia. Tardive dyskinesia is a disorder of movement, probably you know. Tardive dyskinesia can be very, very difficult. So the first message that I'm giving you about atypical antipsychotics in resistant depression is, let's be careful. We are prescribing a drug that can lead to some side effects. After considering this, Which are these atypical antipsychotics? The first is olanzapine. Olanzapine has studies that are confirming some superiority versus placebo, combining olanzapine with SSRI. Interesting. I have one consideration here. Olanzapine is good, but be careful about metabolic syndrome. Olanzapine leads to weight gain, so let's be careful. Second, olanzapine can have some effect on treatment-resistant depression that are unspecific, because olanzapine makes you sleep, sedative effects. Okay, the other is okay. Olanzapine can have sedative effects. Olanzapine can increase appetite, so it has a quick effect on depression. Patients improve because they sleep and they eat, but probably it's not a real antidepressant effect. Second, risperidone. We have some positive studies with risperidone, but risperidone in combination with SSRI is not very popular because risperidone is a very potent D2, dopamine D2 receptor blockade. And therefore, blocking the D2, you have a depressogenic. Depressogenic means create depression. All the antipsychotics that block the dopamine D2 receptor are to be avoided in depression, particularly alloperidol. Alloperidol, never use alloperidol in depression because you will worsen depression. And risperidone would be close to this. So there are positive studies, but I suggest some caution. Then let's come to quetiapine. Quetiapine has a lot of positive studies in resistant depression augmentation. Quetiapine is a strange antipsychotic because the effect of quetiapine is different depending on the dose. At high dose is antipsychotic, at medium dose is antidepressant, at a low dose is only sleep-inducing drug. So it's very important to use the right dose. If you want to have an antidepressant effect of quetiapine, you have to prescribe 150 to 300 milligrams per day. This is the best antidepressant dose for quetiapine. And this is quite effective. I've seen in many patients. Also because quetiapine has a mood stabilizing effect. And moreover, quetiapine is accepted in Europe for treatment-resistant depression. So we are in label, it's official prescription. Which are the problems of quetiapine? Sedation and could be also some metabolic syndrome. So again, use with caution. The last atypical antipsychotic, aripiprazole. Again, we have positive studies. Aripiprazole was not accepted in Europe. Not accepted in Europe for augmentation and treatment-resistant depression, but was accepted in the United States. So, some yes, some no. Why? Aripiprazole is a partial blocker of dopamine receptor D2. So it's not a complete blocker like alloperidol. So it's not the negative effect of alloperidol blocking the patient. It's a partial agonist of D2. And this partial agonist effect of the aripiprazole has indeed some stimulating effect. So you can see some patients that with aripiprazole have more energy because you rebalance the dopamine transmission to together with the antidepressant. So, good, interesting. Which are the problems of aripiprazole? Sometimes aripiprazole can give agitation. Sometimes aripiprazole can give the opposite, sedation, depending on the patient. So again, you must be very careful observing what happens to the patient. We already discussed this. Another option. So you have learned that atypical antipsychotics are a good option in resistant depression, but you must consider many aspects. It's not that simple. Another point, bupropion. Bupropion is a very interesting drug because it's the only antidepressant that has a specific dopaminergic effect. Specific dopaminergic effect. Bupropion blocks the dopamine transporter. And blocking dopamine transporter gives an increase of activity of the dopamine system. So it's an antidepressant that is very stimulating, very activating. Which are the problems of bupropion? That bupropion, as it is activating, can be too much activating. So if a patient has insomnia, the patient can have more insomnia. If a patient has anxiety, with bupropion can have even more anxiety. So bupropion is good, but only for those patients who don't have insomnia, don't have anxiety, don't have agitation. It's good for retarded depression in combination with this. Another problem of bupropion is the risk of seizures. Seizures, you know seizures? Epilepsy. Because at high doses can give this side effect. So this also should be controlled. Keeping the dose low or doing an electroencephalogram to be sure that there is no epileptic background. Other combinations that we discussed. Few words on ECT. You use ECT in your hospital. Use ECT. One yes. ECT. No ECT. Okay, not many use ECT. One yes. ECT has a very negative reputation. Because many people consider ECT like a punishment or so. This is not true. ECT is a treatment for depression, for very severe depression, that is very effective, very effective. ECT can treat more than 80% of resistant depression, very effective. It's not clear how it works, probably like antidepressants, changing the monoamine system, but it works. So it's very effective, well established, and well supported in this. What are the problems of ECT? Poor reputation. People think bad about ECT. Second problem, it's very expensive. ECT is not a pill. ECT needs the machine, ECT needs nurses, many doctors, anesthesiologists, so it's very expensive. Many hospitals don't like ECT for this reason. Another problem with ECT is that someone says that if a patient is responding to ECT, you need to do ECT every relapse because only ECT will work. This has not been demonstrated, but some people say so. Side effects of ECT are not many, some mild memory alteration, but very small. No other side effects. Other options. Today I'm here to give you suggestions. Another option is lamotrigine. Lamotrigine is an anti-epileptic drug that has a very interesting antidepressant finish. Can be added to SSRI. But there are some buts also here. Lamotrigine must be given very slowly. You know there is a big risk of skin rash. I have seen a patient who had a very severe skin rash with lamotrigine. So, very carefully. You need more than 2 months to increase the dose. Second, probably lamotrigine is better for bipolar depression rather than unipolar depression. So, for those cases with bipolar depression or bipolar in the family, that you are not particularly in a hurry, you can consider lamotrigine in combination with SSRI. It can work. Pindolol. We worked on pindolol many years when I was working in Milan. It is not clear what pindolol does. Probably it enhances, improves the serotonin pathway. It is not clear how it can work because data are contradictory, but probably can a little bit make faster the response to the But consider that pindolol is also a beta blocker, so we decrease blood pressure. And for some patients, this is not good. Okay, this we already discussed. I want to focus on the most important point. This is very important. Zinc. Zinc. You know, zinc is a blood element, a normal blood element that we all have. But sometimes, for some reasons, zinc can be low. Therefore, a strong suggestion that I'm giving you in case of resistant depression, make laboratory analysis and check the level of all these elements. Zinc, magnesium, vitamin B12, and folate. Zinc, magnesium, vitamin B12, and folate. You have to do the blood analysis of all those compounds in your patients. Because if one or more of this is low, lower the level, patients can have depression. And if this is the case, the solution is very simple. You give them what they need. They have low magnesium, you give magnesium. They have low folate, you give folate. And the same for zinc. So, analysis of elements in the blood and corrections of elements in the blood is very important. If you are interested in food, I can tell you, because one patient I remember I had 1 year ago, she was low in zinc and magnesium. And then I told her, you need zinc and magnesium. I will give you the pill. And she told me, no, I don't want the pill. I don't want artificial things. Give me natural things. How I can increase zinc and magnesium with food? You know how to increase zinc and magnesium with food? Me neither. I didn't know. So I went in the computer and I checked which food had zinc and magnesium. And then I went back to the patient and I said, listen, you can take 2 things to increase zinc and magnesium. One is cornflakes, you know, breakfast cornflakes. Kellogg's breakfast chocolates. Understood? And the second food that increases zinc and magnesium is oyster. Oyster, you know oyster? Okay. So, these are the two foods that are extremely rich in zinc and magnesium. So, if you want to increase zinc and magnesium without the pills, you can give cornflakes and oysters. How much? Oh, oyster, I think, they're very concentrated. So, a small amount of oyster is okay.
One oyster.
Maybe it's a lot. Okay. Another idea. Now we are talking about secondary treatments. Modafinil. You use modafinil, you ever use maybe the neurologist?
This drug in Russia.
You don't have?
We don't have.
Oh, pity.
It is, we can buy it, but it's forbidden.
Ah, that's a pity. But if in the future you will have the possibility, I will give you 2 words about modafinil. Modafinil is a drug that is used for narcolepsy, patients that fall asleep usually. Modafinil is a stimulating drug, not amphetamine, different mechanism of action, that is very good for narcolepsy. And at the dose of 100, 200, is very good to improve energy in patients. So if in the future you will have the possibility to prescribe modafinil, consider it. Another very important point, estrogens, hormones, estrogens. Particularly in women, after menopause, there is a decrease in estrogens. And this decrease is very negative for depression. So many times in women at the age of 50, 55, I prescribe estrogens, you know, the patch. You put the patch with estrogens. Of course, you have to connect with the gynecologist and ask him, listen, I am the psychiatrist. I'm following the patient that you also know. I would like to give estrogens. What do you think? Because estrogens can have also side effects. Can increase the rate of some tumors. So, estrogens are very good for mood, but as everything, has also side effects. So consider this as another possibility. This is, on the other hand, very simple. You have in Russia for sure, omega-3. Omega-3 is not a drug. Omega-3 is a complementary medicine. Is something that comes from fish. But omega-3 is very useful for depression. It's also mood stabilizing. I use omega-3 with patients very frequently. The doses must be at least 1-2 grams, so quite high, and of course are well tolerated. You could also tell patients to eat a lot of fish, but it's not easy to understand how much is a lot. So you can give omega-3. They are also useful for controlling cholesterol. So you have different benefits. The only problem of omega-3 is the taste. That patients feel the taste of fish in their mouth. Fish, because they come from fish. But no other side effects. Another thing that is quite useful is S-adenosylmethionine. It increases a little bit serotonin transmission. I think you should have in your country S-adenosylmethionine. SAMe is the name. S-adenosylmethionine. Check in your book, but I think you will have. This is also sometimes useful. It's a mild help, but it can be of help. they put some electricity around the nerve here, with a battery under the arm. It's a very slow treatment. It takes 1 year to have benefit. But some patients can have some benefit. It's very expensive. They told me it's about 20,000 euro. I don't know how to translate in your currency, but it's very expensive. So it's something that is not very common. So to summarize this very long part, augmentation is probably the best strategy, the most flexible strategy, but needs a lot of caution, a lot of be careful a lot, because any combination you do can have benefit or side effects. This is important. This is why it's important for you to know all of this, so you can have different options. And you choose case by case which is the best option. The last point I would like to treat is intravenous antidepressant treatment. Intravenous. This idea was originally proposed more than 20 years ago by Bruce Pollock. They tried to give clomipramine. You have intravenous clomipramine in Russia? I think yes. Intravenous? No? Some yes, some no? Yes. Well, be aware of that. If your hospital has intravenous clomipramine, you can use it. Because intravenous clomipramine is very effective. In this study, it's very surprising that in a few hours you have a very quick effect. In 2, 3, 4 days, you have a very quick effect of the clomipramine. In less than 1 week, you have half the amount. So in some patients, intravenous clomipramine can be very effective. Of course, it is complicated. You need the patient in the hospital. You need to check for electrocardiogram activity. You need to check for blood pressure. And then there is also a very strong placebo effect, because when you give intravenous, it's a very strong treatment. But I remember many cases of resistant depression who had incredible benefit from intravenous clomipramine. So be aware that intravenous clomipramine can be a very relevant option. These are many studies that talk about it. So overall, intravenous treatment can be interesting, but of course,